all panelists for your great presentations. We have opened the Q&A box here for the attendees' questions. And I have already two questions here. One was sent in the chat and another one in the Q&A. So I'll start with this first set, and then we'll get more. And I have myself a couple of questions here as well. So the first question, I think it's addressed to Dr. Guy and Dr. Nida on are there any recommendations on how to educate decision makers to engage people living with NCDs with decision power at decision tables? And I already also asked Dr. Anselm the question that was addressed to him. So I just received a comment that my microphone is low. The sound is very low. Can you hear me well? Okay. So Dr. Anselm, considering obesity as one of the main risk factors for diabetes development, is there any suggestion protocol from PAHO, WHO for tackling obesity? This was sent by an anonymous attendee, so I can credit. So this is the first round of questions, and I will follow up with the second round. Dr. Guy?
Thank you, Pedro. Yes. And thank you for that presentation, Dr. Hennis. It's very, very important. Very important. The Global Diabetes Complex will really be a game changer in the NCD arena, and it will be used as a pilot test of this global regional and country initiative on an NCD. The question is a very important question, and it has to do basically with health literacy, ultimately. And it is, how do we empower the different levels of the policy development chain? So while we're empowering the agents of change to push for change, we need, from a bottom-up approach, we need to ensure that the top-down system is working efficiently, that the top-down process from policymakers, parliamentarians, government leaders, ministry, focal points, community leaders, have the necessary tools, knowledge, resources, and health and literacy to understand the impact of policies and programs. And that's a really important process in the empowerment of. We had a very important quote from our consultation. When you empower communities, you empower the whole system. Meaning that if we focus on empowering the community at the community level, it will eventually percolate as a bottom-up approach to mobilize and empower political leaders. But that is also wishful thinking. So the health literacy of policymakers is extremely important. That has to go in parallel with the empowerment of communities. And at WHO, we are working on health literacy approaches across that organizational levels, including political and parliamentarian levels. We are bringing together in a sort of in a virtuous connection between parliamentarians, science brought by WHO and others, and civil society agents of change. We're trying to make that change at the political level. Now, we have extremely good examples elsewhere beyond NCDs. The UHC movement has done extremely well, and the HIV, communicable disease, has also maternal and child health environment, and they have excellent examples of empowerment of not only community level, but also at the political level. We are learning from those experiences and eventually channeling those into our health literacy efforts with politicians and policymakers, but that is extremely relevant. We need to ensure that we are building the capacity and the empowerment from the bottom up, but also at the same time in parallel from top down. And they need to meet in a very interesting and collaborative effort to really look at those the impact of policies and programs. That's my initial comment, but I think that's a very good question.
Dr. Nida?
Yes, thank you, Pedro, and thank you, Dr. Guy. I really couldn't agree more. I just want to add that we also need to perceive those policymakers and decision makers with the decision-making power as part of those communities. So maybe that will change their approach and how they're perceiving any issue when they have turned the tables as we like to say. And that is exactly what we are trying to do with this observatory, to narrow the language barrier, if you wish, between those that are living with an experience or coping or converting their challenges into opportunities, with those that are supposed to be making the decisions based on different other aspects and very minimally taking into account what is the lived experience. So narrowing the misunderstanding between the two languages might also help to bring to the attention of the policy and decision makers as much as possible what is a lived experience, but as we mentioned earlier, not to take it in an anecdotal way, but rather to give it a more robust and more scientifically rigorous approach when we try to bring the voice into the policies. I think that would make also a big difference.
Thank you so much. Dr. Anselm?
Good, fine, thank you so much. Now, this question obviously about obesity, it's a question that can take days to attempt to answer it. And really, as we know, the challenge really has been through the extreme marketing of diets which are high in fats, sugars, and salts, particularly sugars and fats in terms of the region of the Americas. And what we have seen when we've tracked the pattern is that the markets of North America were saturated. So then a lot of the private sector, the manufacturers of junk food and sugar sweetened beverages, then expanded significantly into the Caribbean and more importantly into Latin America. So we've actually produced documents in PAHO where we can show the change in terms of the marketing and the uptake of food, and then it tracks a geographical association with increasing obesity, particularly among younger people. So we know the drivers of the whole issue of the commercial determinants of health and the drivers for the obesity epidemic that we're seeing, particularly in Latin America. And in terms of tackling those issues, one of the approach that has tremendous impact, of course, is regulatory frameworks to tackle junk foods and the marketing to children, taking out the toys out of the boxes of cereals and the other things that attract children, and really pushing regulatory frameworks as well as taxation. This has had mixed results through the world, but I mean, the short answer, some of the best experiences we've actually had have been experiences from Chile in terms of warning labels, front of package warning labels. We've now built up a tremendous body of evidence, probably the best in the world, of the effectiveness of the octagonal front of package warning labels. But of course, when one tries to share the information and implement it, there's tremendous industry pushback. So taxes and regulation and earmarking for health has also been part of the agreement with the ADABA agreements. And again, trying to change the environment through regulation and legislation is one pillar to tackle this issue. Another big pillar, of course, is the area of education and health promotion and health literacy. So populations understand what they're eating and what it means. And this is another pillar in terms of the approach. Then, of course, the environment, the school environment, because if one can establish behaviors early in life in terms of proper nutrition, physical activity in the school environment, you actually change the trajectory of the cohorts coming behind. It's very hard to change obesity in adult populations. You get far more return on changing obesity in those who are most influenced. These are younger populations. So the school environment is a very major area where one has to focus the efforts. Healthy eating, and as I said before, very, very briefly, Brazil basically leads the world in much of its advice in terms of treating food not as ingredients, but as actual food that we eat and how we can enjoy it and how we can reduce the amount of ultra-processed and processed components and have healthier components. And of course, then it speaks to the need to strengthen familial farming and linking that to procurement. And again, procurement has been done very well in Brazil, where the government actually will procure quality foods from certain producers as opposed to junk foods. So I think changing the environment, changing the way you source, changing the literacy, changing the knowledge is all part of it. And of course, the other component, of course, is improving physical activity. Quite often we have forgotten that when at my age, I think you guys are a little younger than me, going outside and playing was very much part of how we lived. Now, the whole idea for kids is sitting there and the only exercise to get is to move their thumbs in some sort of video game. So the whole idea in terms of physical activity being part of the daily life is something that we have to reinforce, make it available in the school system, and encourage after school activities. So getting back to basics. So I hope that answers the question to some part, but it's a very large and very complex topic. Thank you.
Thank you so much, Dr. Ansem. I'd like just to add one small piece, which is my motto here in our meeting since the second or first one, how the urban environment, how the built environment affects also our physical inactivity in cities and how our mobility options do affect also these abilities to be active. So I have a couple more questions. So one very quick question: will countries need to formalize the partnership with WHO to implement and monitor and evaluate the Global Diabetes Compact outcome? And a second one that I'd like to ask to all the panelists. The Global Diabetes Compact shows very clearly in its mission the prevention, the access to health, the role of engagement of people with diabetes in achieving its goals, and then with the activity or the pillars: protect, detect, treat, and recover, very clearly in each phase, and who is targeted and how we can promote health with those pillars. So I'd like to ask you, how can meaningful engagement of people with diabetes or other NCDs can support and can improve the outcomes of these pillars and activities of the Global Compact? So these are the two questions that we have at the table.
Okay, I'll begin. I'll also put in Guide to give a perspective from headquarters, but very certainly the Global Diabetes Compact, what we have now is the big vision, the strategies that we are quite sure will make the difference in addressing the burden of diabetes, the access to medications, inclusion in universal health coverage, among others, and engagement of patients, engagement of whole of society. So what we have is the big framework, the context, the ask. So the next steps now will have to be how to develop the roadmap, how to implement, how to put the meat and the bones, right? How to fill in the gap. So this will be a process that will be an iterative process with the countries and member states, and a series of discussions will take place as one fills out the big vision and operationalizes it. So the question still is that we have the big idea, the big vision, the blue sky thinking. Now we have to land it and make it operational. Okay, so in other words, so I can't give you the answers as the pieces now being developed in consultation, right? So I think all those issues that you raised will be considered, and I think there'll be a really definite framework with all the steps of the process, but that is going to be developed now going forward. Guy, can I pull you into this discussion?
No problem. Happy to come in because I think that was spot on, Anselm. I would just add that one of the basic principles of the Global Diabetes Compact is the co-creation with the community that it's building. So Anselm is exactly right. The blueprint, the outline, the purpose, the mission, the vision, the pillars have been already put forth, and they have been put forth through a collaborative approach with the stakeholders involved. Going forward, it will be a medium to long-term journey, which will continue a dynamic process of really putting the pieces together. And that has been that's a conscious decision. It has been well thought out. And ultimately, the Global Diabetes Compact is a global, international partnership, collaboration. And each of these pillars will be developed down the road and co-created with the different stakeholders that involve, obviously led and focusing on country impact and led by member states. But it will also very strongly invite private sector, civil society, academia, science, evidence, to start building these different pillars. And each of these pillars will then span out and dovetail into particular activities. There's already some ideas, but all these will have their own particular groups and multi-stakeholder groups to sort of really co-create this. Now, across all of these pillars, and that goes maybe, this sort of links to your second question that was directed more to ourselves, that all of these pillars will have an undercurrent of involvement, a meaningful engagement of people living with diabetes. And that has already started, actually. I was mentioning the launch of our report on people living with diabetes, but immediately that consultation was in December. Already at the beginning of this year, in April, we sort of already went forth as a second step from that December consultation and sort of also supported the NCD department at WHO HQ to have a particular consultation with people living with diabetes that we did in December to inform and to start the community of people living with NCDs to be involved and engaged in co-designing the Global Diabetes Compact going forward. So it's a very conscious decision. First of all, I'm involving people living with diabetes, but also a conscious decision of then having a multi-stakeholder approach to implementing the different pillars going forward and designing it with those expertise and those insights. Back to you, Pedro.
Dr. Nida, if you'd like to add anything, please feel free to.
Yes, very briefly, and apologies, I cannot really refrain myself from mentioning again the COVID and the lessons learned, or the lessons we are still learning. We all too well learned that we cannot have systems big enough to answer to the need of everyone, especially with acute disease like COVID, and it's not even recommended or necessary. We are all trying to have more preventative, more upstream engagement of all the sectors to prevent from people coming into the healthcare sector for as long as possible, until they really get to the age in which some of the systems normally or naturally fade away. Now, with this being said, if we draw this lesson back to other diseases, what we have seen through COVID is that there are huge communities and huge societies using the experience of patients who lived through COVID and how they coped throughout the disease or afterwards with the long COVID. In that sense, if we can really, beyond the policy level at the global, national, or regional levels, if we can at the system level try to engage this expertise in a more meaningful, more structured way to be an extended arm of those that have already coped, those that have already coped with the disease or are living with it, to help the others, or their own observations to become part of the decision making for how to not let people reach out to bad choices or provide them more healthy choices. I think that can be something that we would be certainly striving for as a patient community, to try to share our expertise, not only for those that are going through the disease, but as well for those who can, be in the pool of those where disease has been prevented.
Thank you so much. Thank you, everyone. Dr. Ansam, did you open your mic to?
I did. If I may permit me just a few seconds. The second part of the question speaks to monitoring and evaluating the Global Diabetes Compact's outcomes. And I just will speak to that because that is such an important part of the work of PAHO and WHO. The fact that, as Margaret Han would say, if it doesn't get measured, it doesn't get done. So very much the whole philosophy of monitoring and evaluating and measuring impact is very much part of the philosophy. So that will most certainly be included.
Perfect. Thank you all for your very inspiring and very detailed presentations and answers. I think we've passed through all the questions, and we're very glad to have had you here in this opening session of our meeting. And I'll turn it back to Mark for the next announcements.
Thank you very much, Pedro, for your wonderful moderation. And I would like to thank Dr. Gaifones, Dr. Neda Milewska, and Dr. Ansam Hennis for their also wonderful presentations and speeches. I think very inspiring for the groups who will continue throughout the day today to discuss and also to work. So we have working groups on different NCDs and risk factors, and I'm sure that all of them will use insights that you shared with us here on the engagement of people living with NCDs, and obviously on the demands and lessons from the entire health community and the Global Diabetes Compact, there is, obviously a need now to respond to this huge number of deaths and of people living with NCDs, and also the numbers we saw in diabetes of the increase of people developing diabetes and people undiagnosed and people dying of diabetes, which could be many times, as we know, prevented. So and besides hearts, that in the opening also Rafael mentioned, that is now a mission in Brazil, and this clearly will be a mission that will help also to have the Global Diabetes Compact succeeding here. So to achieve the goals of the Global Diabetes Compact in Brazil. And Guy, thanks for all your efforts for engaging people living with, and this call for all the different sectors and governments to keep engaging. I think that there is still a long way there to go to make sure that people are truly engaged in the decision at the decision tables. But it is wonderful to have WHO leading the way, opening the door, and I think this is very encouraging, and towards a brighter future, healthier future. Thank you all very much.